important note, we ask that you please not use AI recording or note taking for this session. The materials presented today are proprietary for the speaker themselves. So just that you are aware of that policy for us. It is now it is now for me to introduce to you June Stark, CMSNE President, and she will share with you some chapter bit.
Thank you, Maureen, for that excellent introduction. So yes, I'm June Stark, and I'm the president of CMSNE, and we want to welcome you to our third Pediatric Special Interest Group webinar. We're really proud of our Special Interest Group initiative, which we call SIGs, because it's a way for CMSNE to reach out to our community of pediatric healthcare providers and support them through specific focused education. This is the last webinar in the series, but I want to let you know that we're committed to pediatric case management and social work education, and we are making the commitment that in all the programming that I'm going to share with you in a minute, that there'll be a pediatric lecture element or focus that you can count on. So we're committed to all of you. And the topics that we cover are often general, so they're really applicable to the whole healthcare profession. I want to share a little bit with you about our organization. CMSNE is one of the chapters of the Case Management Society of America, abbreviated CMSA. CMSA New England is one of the largest chapters in the country with over 300 members and growing all the time. So we really want to encourage you to consider membership if you're not a member yet. The other thing, besides being one of the largest, we're one of the oldest, and this is one time when being old is a good thing because we're over 38 years old as a chapter, and that means that if you become a member, all policy procedures and processes are very well established, and there's great benefits to you for being a member. We also cover 5 states, that is Massachusetts, Rhode Island, Maine, New Hampshire, Vermont, and recently just added Connecticut. So welcome to all of you from all the states. Plus, because of social media and our advertisement, we have participants today from many states in the country. Maureen, to become a member, it is $170 for CMSA, the national membership, and $35 for the New England chapter, any chapter that you choose, for a total of $205. But we figured out through the membership committee that that amount is equal to about 4 cups of coffee a month. Also, another advantage that CMSA offers you when you join is a flex or easy pay, and that turns out to be $14.66 a day if you decide to do that. Next slide, please. So we have a new calendar that we put out all the time. We update because we're really in a phase of great growth, and we're doing lots of programming. So this is our calendar. It shows you all that's coming up. And if you become a member, you automatically get this. And then you could also call the office or go to our website if you're a non-member and keep up with what's going on. Next slide, please. So the most current things happening and the largest on Saturday, September 27th in Portland, Maine, beautiful Maine in the fall. Come join us for an in-person conference. Next. And then in November 7th at St. Anselm's College in Manchester, New Hampshire, another in-person conference to be looking forward to. So we have in-person and we have virtual. And between this, we have many webinars being planned to keep you up with current events in healthcare right now. So take a look for that. And one of my favorite conferences coming up in January and February virtual conferences is the acute hospital. So without any further ado, I'd like to recognize our sponsor, and our sponsors are so important to us because they make our programming possible. And so I'm introducing Daniel Cunningham, who is the Director of Business Operation at Maxim Healthcare and Home Care Services, a national provider. Daniel, thank you very much, and please take over.
Hi, everyone. Thanks for having me, and definitely very happy to be a sponsor. So I'm just going to jump in and tell you a little bit here about Maxim Healthcare Services and what we're also doing here in Maine, but nationwide. Just a little bit about who we are. Maxim has been around for almost 40 years now, so we also, another good thing where age is good. And we are in 40 different states, so we are a large nationwide company. Even if we don't have a brick and mortar location in a state, we are servicing those almost all states. And we have over 150 offices nationwide. Here in Portland, Maine, um, we currently have over 100 dedicated caregivers, and we're servicing 75 plus patients throughout the state. We specialize in private duty nursing services. So just a big misconception is that private duty means private pay. That is not the case. The private means that the nurse would just be working one-to-one with the patient. We service both pediatric and adult patients. We are about 75% of our patients they are pediatric patients here in the state of Maine. We do accept Medicaid and most commercial insurances when it does come to payer sources, as well as veterans also. And we are accredited by the ACHC. Just a little bit more about private duty nursing. We specialize in hourly skilled one-to-one nursing care. And we could do this in the home, in the school setting. Sometimes we have members that go to community learning centers as well. We want to make sure that our patients are getting the care needed. So sometimes we will work with the state to get special approval to have our nurse provide care in wherever the patient needs to go. We do provide both RN and LPN services here in the state of Maine, as well as other states throughout the country. We do unskilled services as well. Here in the state of Maine, currently, we do not do much of the unskilled services, but it is something that we are looking to get a little bit more into. And just the goals of private duty nursing, we are looking to assist in improving the patient's current condition. Obviously, we are looking to prevent decline, and we also keep the patient in the home, and we look to minimize hospitalization. Just a little bit more about private duty nursing. This is just some of the care that it would include: skilled assessment and observations, medication administration, diabetes management, wound care, respiratory management, which does include trachs and vents, enteral feedings, and IV infusions. So our patients are receiving hospital level care from our nurses in the home. We do have extensive vent trach training programs, and we will always make sure that our nurses are top notch, their skills are where they need to be, so that our patients can receive the best care possible in the comfort of their home. Just some examples for when home care might be recommended. Certain disabilities, whether that's physical, developmental, or behavioral, chronic illnesses, catastrophic injuries, complex therapies, palliative care, cardiovascular, respiratory, GI, chronic and acute wounds, along with many other things. Are most common, that we will see, are those chronic illnesses and those disabilities. And our job and our nurse's job is to make our patients as comfortable as possible while they are home. Look to make our patients have progress as best that they can. But also, with a huge focus on having the care provided in the comfort of their home. And just why home care? Why not, have someone stay in a hospital or facility setting? It's the most cost-effective healthcare delivery, right? It is very expensive for the families, and everyone involved to have patients maintaining and staying in the hospital for extended periods of time. Getting them home does avoid facility-based infections. We do see that a lot, unfortunately, when patients do have to go to the hospital, coming back to the home, they sometimes end up with other infections that they didn't have prior to going in. It allows the patient to be cared for in the home with the family support. That's where we really see the big strides is just having the families together, and it allows the patient to receive care outside that hospital or facility. And it really, in their home environment, they tend to thrive more, and we tend to see more positive outcomes. It offers individualized services that are tailored to the client's healthcare needs. So each plan of care for each patient is going to be based on the patient's day-to-day needs. And with our nurse there one-on-one with the patient all the time, we are able to, identify what those needs are and, have that implemented so that nurse is providing that best care possible for the patient. Our nurses really get to know those patients really well, just because they are with them for the full shift. And we get to see those that progress being made, but also prevent any illnesses or anything, because our nurse is able to identify them early on, which could then improve or reduce the risk of hospitalization due to any type of infection or virus that we're able to catch early. It just improves the overall quality of life and the clinical outcomes, right? So it allows these patients to be home, to be surrounded by family, and have a great nurse come work with them for the full shift, and all that focus is then on the patient and then making positive progressions and strides to make their life better. Thank you again very much. We really appreciate the opportunity to be a sponsor for this webinar. And I did put my contact information there. I know that we have quite a few different states on this call. However, I work closely with all other states. So if anyone has any questions or anything, even if you are not in Maine, definitely don't hesitate to reach out to me, and I'll get you in contact with a representative from the state that you are in. So thank you, everyone.
Thank you very much, Daniel. That was very informative. Helps us to preserve our patient quality through using our transition resources, and yours is very valuable. Thank you. So I'm going to introduce to you Ellen Fink Samnick, which is an honor for me. She's a colleague, a super expert, and a friend. Dr. Fink Samnick is an award-winning industry entrepreneur who empowers healthcare intra-professional workforce. She is a subject matter expert on health equity, workplace bullying, violence, ethics, professional case management practice, and trauma-informed leadership. Dr. Fink Samnick is so well published. I'm sure her articles run way over 100, and one of her recently published publications is her book, The Ethical Case Manager Tools and Tactics, which is on my bookshelf for many years and really is a mainstay for case managers. Ellen serves the industry through a variety of roles with academic appointments at Cummings Graduate Institute of Behavioral Health Studies, George Mason University College of Public Health, and University of Buffalo School of Social Work. She is a clinical supervisor, trainer, and instructor for the National Association of Social Workers of Virginia and Metro DC. For her distinguished professional and academic work, Ellen is so well awarded, and we're so excited because this summer CMSA awarded Ellen the National Case Manager of the Year. Congratulations, Ellen. And then on top of that, the National Association of Social Work Life Achievement Award from the Virginia chapter. So it is a great honor and pleasure to introduce Ellen and remind you, if you have questions, put them in the Q&A at the bottom of your screen and we'll answer them at the end of the session. Ellen, take it away. Thank you so much for being here.
Well, thank you, June. My goodness, what a welcome. As some of you know, and I see so many names of friends joining us today, which always just gives me incredible joy. This chapter adopted me, I would say, as a member, an honorary member, many years ago, early on in my case management career. And so when the chapter said, Ellen, come talk. We need your fierce voice on whatever timely topic you think is relevant, but it's going to be for peds. At which point I said, A, I got it, but B, more importantly, I started in pediatrics within large hospitals, small hospitals in the New York metropolitan area. I was trained at Children's Hospital in Buffalo. So not a far stretch for me to say, yes, I'm in, yes, I can speak on pediatrics, but this topic especially is among many of the very timely and important topics for all populations, but especially peds, particularly as we see such growing numbers of pediatric chronic conditions and an assortment of chronic illness concerns. So some of you that have seen me speak before and those that have not seen me speak before are about to learn I'm an incredible storyteller. Many of the stories I tell are based on prior case scenarios or a composite of them. So let me share a composite with you today. A mother brings her 8-year-old to the emergency department for symptoms of nausea, abdominal pain, and loose and bloody stools. It is their 6th visit to the ED in the past 3 months, and she's petrified. He's not better. He's losing weight, she says. The physician enters the cubicle, sees the child kind of grab their belly, and does a very cursory evaluation, doesn't ask for any labs, no other diagnostic evaluations of any type. And he looks at the child and goes, oh, the pain can't be that bad, little man. Show me. Child rubs their abdomen, and the doctor kind of turns to the mother and says, it looks like you were here a few times this year. And then he kind of looks at her up and down. And he says, the nurse gave you discharge instructions each time. Did you follow them? Now, English is not the mother's primary language. She's absolutely exhausted. She has been up all night with her child and over the day for the last several weeks on and off, especially the last few days. Her husband works nights, so was not able to come to the ED with her. And she feels like she has tried everything that has been told to her, every bit of guidance provided. And she was frankly worried and scared to bring the child back to the ED, maybe embarrassed, as any parent might be, worried that why is my child not better? Clearly, I'm not doing something right. She understands what the physician is asking her to a point, but not fully, because she is just on emotional overload. So while she has good English proficiency, in times of stress, well, we're all healthcare professionals of one discipline or another, and we know what happens. Our brains leak out our ears. We're not able to process as quickly, and she feels like she's being barraged. The doctor then says, well, your child's not getting enough fluid. Make sure they have enough fluid. I bet they don't like their vegetables. Make sure they have juice. Starts to go over a whole list of more direction and ultimately discharges the child home. He walks over to his device and he starts to document. Mom is overwhelmed. I doubt there's a father in the home. He turns to the nurse who was in the room with him and says, I'm really worried. Do we need to call CPS here? And the nurse kind of looks at him and they decide, well, that'll be a good idea. So CPS opens a case. They call the family for a visit. Mother says, of course, they come. And at the door, they are greeted by a very worried and distraught father who just says, oh, thank you I tried to call the police. Your timing is great. Maybe you can help. My son is very sick. Something is very wrong. He needs to go back to the hospital. CPS worker comes running in, assesses the scene, sees the child's running a very high fever, is worried the child is now seizing. She calls 911. They're there in a heartbeat. She's already thinking there is no abuse or neglect here. The family has done everything right, bringing the child to repeated providers who dismissed the symptoms and got into a mindset of clearly the parents aren't doing what we ask. They get to the ED. He has a white count of 29.2, which those of us in our space know that's kind of high enough. And his ultrasound shows a major obstruction. He's immediately admitted to the pediatric ICU. And after an extensive workup of stool tests and blood tests, the consultant, who is a pediatric rheumatologist, along with a pediatric gastroenterologist, come in and inform the parents that their child has been diagnosed with Crohn's, and what they have been seeing is an inflammatory response for the body, and they proceed to do some psychoeducation. Now, I recognize that I am not seeing you all other than the little boxes, but this is an opportunity for you to please feel free to use the chat if you would like, whether it is on the top of your screen or the bottom of the screen, because I'm going to ask you a series of questions, and you can certainly feel free to put yes or no in as I ask them. I'd like you to acknowledge with either a yay or nay if you, a family member, your child, a nephew, godchild, or anyone in your life has ever experienced any of the following: had the pain or the severity of pain dismissed or devalued by a provider, had a healthcare symptom or severity of a symptom dismissed by a provider, had a healthcare symptom or severity of symptom attributed to just too much stress, or you're in the biz, you worry too much, you know too much. Been told that you're overthinking symptoms, had a diagnosis and or treatment delayed or deferred, been told to stop self-diagnosing and get off the internet, or somehow left a provider or a healthcare space feeling you are not safe, seen, heard, valued, or respected. As I look in the chat and I see all the yeses and the explanations, my heart breaks for all of you, because I am in there with you. Because if you have answered yes, you, family member, your friend, your clients, your patients, they have been a member of medical gaslighting, one of the fastest rising epidemics within our healthcare space. So in our time together, which I appreciate and value, we had a lot on the front end to discuss. My content will run just about an hour, so we might go a little over, I think the 1 or 1:15 mark, but I will try to keep it very focused and comprehensive so we hit it all. We're going to talk about a few things. I recognize that while a lot of you are from pediatric settings and spaces, not all may be. So we're going to do some general level setting about what medical gaslighting is. And I also, let me stop myself. I want to thank everybody for what you're putting in the chat. I always value when folks feel safe in a space to present their perspective, and really am honored that you all felt so comfortable to contribute to this initial part of the session. So thank you again. We're going to talk a bit about topics that put this on certainly our case management, our healthcare radar, which is looking at the economic burden and the clinical burden of medical gas line from a population health perspective. And when I give information like that, I also like to do two other very pivotal things, because I don't like to just toss things out there and go, okay, guys, here's all the info. And then you are left wondering, now what? I'm going to give you a roadmap, what I call an ethical equity advocacy roadmap of some key touch points that you can incorporate within your own practice. Perhaps you already are, but they will cue you in the moment of what you could be looking at to support your own efforts. And certainly, as I always like to do, I will align all of our conversations with what our industry established resources say. Because when we are looking at equitable care, patient inclusive care for all patients and populations we work for, that is a very daunting, very, very daunting experience. So to that end, how do we ground it? Well, just saw an article today on this topic reminding us that our professional, ethical, legal, regulatory requirements and obligations are grounded in our standards of practice, in our state laws that underlie our licenses, whether social worker, nurse, physician, PTOT, speech, pharmacy, counseling, rehab, vocational. I could go on, but all of the wonderful disciplines that comprise our interprofessional and interdisciplinary teams, as well as our credentialing requirements, all of those set some very clear parameters for our practice. Two disclaimers, one typical one, that everything I am presenting is based on fact. You will see attributions on every slide for the current research that it stems from, as well as a pretty robust reference list at the end for those that like to dig deeper. The other thing is, if during the context of the session I mention a product like texting using one's iPhone or tablet or something like that, I'm only mentioning those products for the purpose of example, not for endorsement. The other thing I like to say when talking about some of the more tense topics today in our world, and one person actually who is a longstanding member of this chapter years ago said, Ellen, you just go to those deep, dark places no one else wants to go. And that's, what our ethical realm does. It brings us to those spaces, but these can be very tough topics to discuss. So please know that when I present information, it's all about education. It is not to dictate this is my way or the highway. I'm not that kind of an educator or a professional. I've never been. It's always been, we're a partnership. Here's the information. I can give you the best at my disposal. I can give you what the industry guidance is. I hate the terminology best practice because it's good for a hot second, not even minute, because by the next second, there'll be another best practice coming down the pike, especially these days. But it is to give you some information to consider, and then how you want to actively integrate that within your space, within your practice world. Go for it. So let's start with just a basic primer, medical gaslighting 101. And I could live on this slide for a long time. And I think some people know the terminology gaslighting from other spaces, from bullying, from relationships, where, the premise is that a person is made to believe that their reality, their perception of what's happening isn't happening, that they're somehow being manipulated, that they question the events differently. And we see this in relationships, It happens in the workplace. It's a very fierce dynamic in workplace bullying, which is another topic I often talk about as impacting our healthcare world. The experience can be viewed as, oh, you didn't remember it correctly. And it comes really from kind of these ideologies about systemic racism and power in the treatment relationship. And so when we, look at it in the context of healthcare, we think about all of those systems and structures and hierarchies and even communication patterns of power, who talks to who talks at who, how information is understood, even terminology when we look at things like adherence versus compliance. I went on a tear a couple of years ago about, when we're talking about compliance with treatment, compliance is about rules and regulations. But when you look at the history of the use of the word, it's about patients being told to do things by that medical model, by a physician-led team from a time where it was the physician that would state what the reality was, what someone needed to do, no questions asked. Something that's very different from the interprofessional partnership, patient engagement, motivated patient, shared decision-making space that we so try to create. The other thing when we're looking at gaslighting and medical gaslighting, it really reinforces some of the barriers, those systemic barriers put in place that we look across distinct populations, which is some of the current terminology that I'm not sure if I'm feeling 100% good about. But there are many, 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 many populations that comprise our culture. And a number of people and groups within those populations are viewed as bio-others. And these are the issues that impede their access to quality care, impact equity of care. So this is how this topic gets very much pulled into this conversation. Now, when we're talking about this topic and, medical gaslighting, this is more than just a parent disagreeing with a provider about the level of pain of their child, or worry that they have, different treatment perspectives. Perhaps they come from a culture that healers are very much part of the process, and those views may be somewhat counter, especially in terms of use of certain medication, antibiotics, blood transfusions, particularly when we're looking at specialty treatments. This is more than going to a provider, going to a primary care provider who may not feel comfortable admitting, hey, I don't know it all. And that as a result, it feels like the parents questioning which they are, because parents, when it comes to getting care for their children or any family member, it's going to be a high level of advocacy, right? Stop and think for a second. Someone near and dear to you is in pain, needs help, has symptoms not abating. You're going to be merciless. At least I would be. In fact, I can be, and probably doesn't surprise anyone. I think most case managers I know, most social workers I know, most physicians I know, when it comes to their own, oh, stay out of their way. It could also be that, case managers, well, there's some frustration we have about families coming in, families calling, for my colleagues that may work for health plans or other large healthcare organizations. You get the patient or the family on the phone, and they're providing you every experimental protocol and treatment information and resource that they have found on the internet. Even, thinking about Daniel's comments on the front end about what's covered, what's not, and remembering families coming up to me and not really understanding what wasn't covered because they found written somewhere, somehow, that something was covered. So suddenly your voice isn't valued. we're not talking about those common realities that are a part of when you communicate with other people and getting on the same page. We're talking about when people, often providers, unfortunately, often members of the healthcare workforce, have less accountability for their actions. They become dismissive, they cut people off, they become incredibly disrespectful of the patient voice, which is a very big issue, especially in terms of quality improvement. They may provide incorrect treatment. That is, the patient or their family question, they say no. Maybe the diagnosis becomes so grossly delayed, as happened in the case scenario, that the person is put at risk at harm, incredible harm. Maybe there's refusal to treat. Maybe they won't listen to them. Maybe they just cut them off with every time they ask what seems to be a very fair question about their care. And it starts to feel like a power struggle. Maybe not meant start, but is a power struggle because it's about control of a conversation and power. And there's that power dynamic playing out. This quote comes from an amazing article. I say that a lot because I'm just such an avid reader of the research. But there is no doubt, and I think we can all stop and think, patients come in, their family members come in, they want very much for the person before them to listen to the version of reality that they are presenting. And when they don't get the answer they want, it becomes a blame game. And in terms of practitioners, even many of us within the case management space, where they feel like we're the cog of the wheel, we are the team leader, if you will. We're the ones that are acting as a gatekeeper, locking that door, keeping them away from accessing the quality care that they need. And we could think of all the ways that it plays out in the standard healthcare space. Unfortunately, I had one of my closest friends die just about a year ago, when horrible ageism in the moment. She went for her standard physical, came in with some different complaints this year. Relatively healthy woman in her early 80s, been one of the first people I met in the healthcare industry over 40 some odd years ago. And not really a complainer, and went to the doctor with her partner, had some weight loss, some stomach and back pain, and immediately the practitioner dismissed it as, oh, well, you are of a certain age and, probably have arthritis. My friend had never been diagnosed with any arthritis in her life. She lived in Manhattan, walked avidly, kept it in good shape, never an issue. Sent her home with some an anti-inflammatory that we'll just leave it there. All that did was further depress and constipate her. Appetite was already bad, mood was already bad. Didn't really feel much better over the last couple of months. Next couple of months, 4 months later, goes back, complains again. And along with some emails over the months with the portal that, okay, not getting better, still no blood work, still nothing. Oh, there's a flu going around. The primary care physician every time said, no, there's, just some other symptom. There's a stomach flu. Oh, you had a vaccine, as a result, on and on and on and on. Ultimately, I'll cut to the chase of the story. 3 months later, in excruciating pain, was brought to a hospital emergency department and diagnosed with stage 4 liver cancer that had metastasized and was everywhere. And she died 4 weeks later. So at that point, and the term gatekeeper is loose, the health plan the person had required that the primary care physician actually be the referral source to other specialists. So this is and she knew that, and why she didn't even advocate beyond that to try to see somebody, because she would have had to pay hundreds of dollars to see a specialist, which she couldn't afford because she was on a limited income. So within the pediatric world, what are we looking at? Well, plays out in many of the same ways we would expect that medical gaslighting would appear in the regular space with adult patients. We see things where healthcare providers dismiss the child or the parent's complaint. They attribute what's happening to the child being stressed about school, having too much stress put on them or expectation put on them by parents, peer pressure, get them off social media. They attribute it to issues where there are health literacy challenges because the family views things differently from the provider. There could be issues around not communicating with the provider appropriately, courtesy of digital health literacy challenges where they may not have access to the portal, they may not be able to use the portal, they may not be able to understand the psychoeducation provided or the resources provided because they have limited Wi-Fi access to the internet, or there were updates perhaps to their device and it's not working properly, and they really are challenged in understanding how to best work it, or the child is being raised by a grandparent that doesn't have technological or digital health literacy. And maybe there is stigma around mental health, and there's a worry the child is making things up to avoid going to school, or doesn't really have mental health issues and is attributing it all to ongoing health challenges. You could go on and on. Now, medical gaslighting plays out in different ways. And when we see it play out, and I try not to be a slide reader, so hopefully if there's anybody that needs any visual accommodations, you are capturing the closed captioning that I am saying, and I'll try to speak with enough level of detail to the slides so that you can capture the essence of what they mean. But, take this particular case example, and this is a real situation. This young man came down with some flu when he was 9, and it took about 2 or 3 years for him to get a formal diagnosis of rheumatoid arthritis, which I don't often like to give in children, but there is an increasing prevalence of it. And the physicians, every time mom would bring him to a pediatrician, would bring him to an emergency department, would bring him to an urgent care setting, they kept saying, oh, your mother is too close to you, too much mothering, you're an only child. They would not give them meds to manage the pain and other symptoms. And the practitioners basically started to take it upon themselves to treat without a diagnosis, say that they were taking too many pills because there had been some recommendations made by a practitioner that the primary care did not know, and ultimately was provided a diagnosis of rheumatoid arthritis, which then they subsequently got treatment for. Now, why is this such an issue? Well, here I go. You got to have data in a session like this, and I promise it will be a light lift. What we are seeing is a very, very fast rising, unprecedented number of youth that are experiencing an onset in 6, 7 through 14 years of age of chronic conditions. So pediatric onset of, excuse me, autism spectrum disorder certainly is part of it, asthma and respiratory disorders, seizures, and epilepsy, prediabetes, musculoskeletal issues, as well as rheumatoid, and a host of other issues. Some and I've refrained from really starting to use the term expert because I don't think, as honored as I am when I'm called an expert, I'm like, nobody can be an expert these days. Things are changing too fast. But a lot of researchers and thought leaders attribute this to changes that happened during the pandemic, worsening mental health that then impacts the immune system, since we can't separate health and mental health, and increasing prevalence in those disorders as well. And so we're looking at least 30%, maybe about 32%, 1 in 3 youth, 25 million, between the ages of 5 to 25 have been diagnosed with a chronic illness in the last few years. We're also seeing tremendous shift in pediatric appointments. So I love following data like this. And I want you to stop and look at this number for a bit. The average pediatric well care visit lasts 71 minutes. Now, you first see that and you go, 71 minutes? Ellen, what are you saying? No, it doesn't last 71 minutes. You got travel time, whether public transportation or other means of transportation. You've got check-in time. You've got completion of any documentation paperwork, especially if it's a specialist. You've then got waiting. Then there's triaging. You go into the room, nurse practitioner, physician's assistant comes in, they check your vitals. Maybe a medical assistant does some preliminary documentation and dialoguing. And then there's an actual visit, 11 to 14 minutes. And then they're out, having to then repeat the cycle to leave. And this doesn't include things like vaccinations, anemia screening, x-rays, labs. Your 11 to 14 minutes covers that stuff. How much time do you really get to speak to a provider? How much time does a parent get to share their voice? And if they are a family of color, if they are a family of different ethnicity than that of the provider or that of the area, they're going to feel like their voice is not as important. It will be harder for them to advocate, and often to the point where they feel they're not heard and they have to advocate louder. And we're going to come back to that point. So ERCI is a very large research group, and they focus on looking at safety and quality issues within the healthcare industry. And they come out with a big report every March, April on the top 10 safety issues in health. Now, you could probably sit and guess what they might be. And I feel like, we can do the drum roll, please, because each one of these are very big risk management opportunities. So, changes and deteriorating working conditions in community pharmacies, inadequate coordination during a patient discharge, too many voices, poor communication. I just saw another data point about that the other day. Ongoing issues with infections in long-term and continuing care facilities and communities, diagnostic errors related to certain diagnoses, particularly cancers, vascular events and infections, drug compounds, substandard drugs, falsified drugs is a big issue. I know we sometimes have folks that work in the military or the VA. This has been a longstanding issue throughout even my tenure in the industry, where veterans come into non-military health settings and their records aren't there, and having to catch up with what's been going on, cybersecurity breaches, spread of medical information, misinformation, insufficient governance of AI, which is rapidly changing. But let's get to the most critical part of this slide. The top 10 safety issue, the top safety issue rather, in healthcare last year was dismissing of the patient, family, and caregiver concern. That means that that issue appeared more than any other of the thousands and thousands of people that were contacted by ERCI for this survey. And that continues to come up when they ask, what's the major issue? And so, what we see are persons who know that something's not right with their child. They know that their behavior's off. They know that this is not the same child that they gave birth to. And they often know that something has happened long before they get a diagnosis, and certainly long before it's acknowledged by a member of the healthcare team. And, stop and think, how often do parents share this with you? How often do they share questions that they may have about clarifying diagnosis, prognosis, or treatment? And for those of you that are parents, or maybe you are parents of a child with a serious illness, how often are your questions dismissed? Now, I mentioned some of this on a prior slide, so I'm going to hit this very, very quickly. But we know that the symptoms can be incredibly subtle. There can be incredible delays, and anybody that has a chronic condition, stop and think sometimes how long it takes, how many providers one needs to see before a formal diagnosis is in play. How long? And, when we're looking at more than 40% of children and adolescents with chronic pain reporting at least one time where they were dismissed, whether they went to a doctor, whether they were in school, whether they approached a parent. And so it gets caught up in an incredible dynamic where parents don't feel psychologically safe to discuss this. We have what we saw in the first case scenario, where the parent was suddenly being blamed by the provider. Judgments were being made about the parent, which were not accurate, as well as by other members of the team, to the point that Child Protective Services was called, and they ended up probably saving the child's life. Parents, particularly, again, parents of more marginalized and minoritized communities, may feel that this is power and they can't fight the system. And so they will feel incredibly reluctant to share their concerns. The staff will view them as demanding or uninformed, or somehow blame them for neglect or abuse of their child. It's unconscionable to think of how unpsychologically safe someone can feel. And of course, what would a case management presentation be without some mention of the clinical, fiscal, and operational burdens faced by our employers, or a drain on the industry? But truth be told, this disruptor, this dynamic, leads the pack with that. Because when we look at the families who are struggling to try to provide good quality care for their child, and now on top of that are dealing with a chronic condition, we're talking about more than 80% of these families experiencing some sort of financial hardship, well, some sort of hardship overall. Let me put that 80% number in context, with about 70% having some sort of financial hardship, inability to pay co-pays, out of network costs because the specialist is not part of network. 50% have other kind of health-related social needs, social determinants of health, social risks, social influences of health, whatever your language of choice these days is. Challenges with social support, limited support from family members, employment challenges, stability of housing, and close to 50% had to actually borrow money to address their child's healthcare needs. And so then we also have the fact that close to 20% of the world population identify as persons with disabilities. And why do I bring that up in the context of this presentation? Well, number one, they are the largest minority group in the world at this point. So what happens, though, when the parents of a child with disabilities, or when the parents have a disability, because we're seeing a greater number of chronic conditions where children qualify under accommodations as needing specialty care needs. And that's a bit to chew on. And then we look at all of the people that have what we call invisible disabilities. And this is rising. And particularly when we're looking at the scope of this issue in the pediatric world. So, invisible disabilities, those disabilities, impairments, impediments to functioning that we might not be able to see. Anybody suffer from migraines? Right? Anybody suffer from brain fog because of having COVID at one point, or other autoimmune disorders that physically I look fine, but with too much stress on my immune system, well, tell that to the parts that mess with my GI tract, right? So I have what's identified as an invisible disability, or some have suggested that. But what does this mean in this new and rapidly emerging space of pediatric chronic illness? Well, we mentioned the focus on autism, but also POTS, autoimmune disorders on the rise, like irritable bowel, pediatric lupus, rheumatoid, I mentioned, fibromyalgia, migraines, early onset of diabetes, juvenile diabetes is growing rapidly, cystic fibrosis, long-standing issue. Even though a formal diagnosis has not been made, well, we still have the issue there to deal with, and so is the dynamic for the family, again, where they're dismissed, devalued, as is the voice of the child. "96% of chronic illnesses, 96% are invisible disabilities." Chew on that for a little bit and think about that in the context of your patient populations. So before I tell you what to do about all this, one big issue. What happens when the parent advocates for their child? Any parent, any family member. It's pretty fierce, right? Nothing's going to get in your way to keep your child safe. What happens when it's a person of color? What happens when it's someone from a more marginalized community that feels that they need to be louder to get what they need for their loved one? So there was a very big study that was done about a year and a half ago now through the Commonwealth Fund. And they looked at bias in healthcare, but they looked at it from a very interesting lens. They looked at it from the lens of bias by healthcare professionals against different populations that they work with. And what they found was more than 50% of the time, a member of the healthcare workforce, a healthcare professional, was seen treating a person of color and a person who was white differently, even though they said the same thing and delivered the messaging in the same way because they were viewed as being belligerent or aggressive. And imagine the scenario. A parent, a sibling, a grandparent of a child, a youth, an adolescent, a young adult in pain is trying to communicate to a provider, a case manager, that they need further answers, further clarification. And maybe they look like me, and I can be pretty fierce, and I'm in my fierce advocate voice saying that I need help and assistance. And imagine next to me is a person of color. Perhaps they're Black, perhaps they're Latinx, perhaps they are Asian, delivering in exactly the same way, the same messaging to the provider. More than 50% of the time, the person to my right, your left, the person of color, would have security called, be escorted out of the facility for fear that they were going to somehow assault or harm the provider. That study was then expanded to Canada and Europe, and the findings were the same. And it was glaring. And for me as a long-term healthcare professional, it was very concerning. So what do we do about it, Ellen? Tell us what we do. I recognize that it is already 1 o'clock. Again, I know that we are going over by virtue of the way things are set up, and I will try to move through this quickly. If for any reason you do have to get off, though we haven't seemed to have lost anyone yet, we will account for that, though I know you all want your CEUs. So let me get to it. So what does it mean to employ ethical equity advocacy? Well, let me make it simple, because I'm all about making it simple, even though these are very complex topics. Here you go. 4 stops, 4 exits, if you will. Heeding what our established resources of guidance are, and I'll talk about that quickly. Promoting psychological safety, employing advocacy, and modeling and mentoring. So let me move through this quickly because I think a lot of it is self-explanatory. And I think when you stop and you think, you'll cue yourself and go, okay, great ethical models. First start with, what do our established resources of guidance say? And for our health care and case management industry, that counts for what does Joint Commission, what is the National Quality Forum, NCQA or URAC, depending on if you have case management accreditation or other sorts of specialty accreditations, even potentially magnet status. There is very clear guidance. I'll show you in a minute in slides. What does the regulatory compliance say? I get it. It's changing. What things are being called is changing. But at the end of the day, our professional obligations are sacrosanct. They matter more than executive orders, which are not law. And we have to remember where our professional obligations are to the patients we serve and how that is defined also by our codes of professional conduct, our standards of practice, our codes of ethics, and then some, where the messaging is quite clear. Quite clear. From an organizational accreditation standpoint, it's always nice to check the resources day to day, week to week, and know all of these are still in place. I mentioned them on the other slide in the interest of time, but dependent on your organization and which of these accreditations apply to you, whether through NCQA or URAC, whether magnet status, all of them speak to the importance to have objectivity and integrity and really pay attention to the patient voice in care and incorporate that. And words that have kind of lost favor across some organizations lately, and diversity, equity, inclusion, belonging, and promoting inclusive perspectives to practice where every patient's voice is heard. From a regulatory standpoint, So in 2024, Health and Human Services passed the Rights of Conscious Bill, and while this bill has taken many iterations and forms over the years, it's still in place and supported by our standards of practice, where there were always caveats that in the event it is not in the patient's best interest for you to care for them because of some differing in perspective, there is a process in place that should be in place by your organization for you to step back. And this is where I always refer that people dialogue with their HR and the powers that be about what those processes are, should they feel that their personal views and values make care for someone unsafe. From a regulatory standpoint, CMS continues to define their framework for healthy communities. This was what was previously called their framework, their health equity framework. The five touch points really have not changed much. That speaks to looking at inclusive data and making sure that health literacy is addressed, that access to care is addressed. It may look a little different from what we knew, but the tenets of it remain the same, as does Joint Commission's Excellent Health Outcomes for All, which was their health equity accreditation resource site, and continues to support inclusive care communication by the workforce to enhance patient care and quality. For those folks that have their case management credentialing through CCMC or CDMS, both have clear requirements and principles that speak to respecting autonomy, self-determination, the inherent dignity of each patient. A lot of this language is really constant across any of the credentialing. Even ACM has embedded within their standards professionalism and patient self-determination as well, while they don't have a formal ethical code like CCMC does. When we're looking at this from the lens of CMSA, well, lots of the standards of practice speak to this topic, including the most recent added standard of diversity, equity, inclusion, and belonging, and health equity. For those that are CMSA members, you do have access to these standards. Again, not going to read specifically from them, but know that we are all beholden to those standards that underlie our license, that underlie our credentialing, and underlie our certification. The American Nurses Association came out with their new code of ethics just this last year. There are 10 provisions, and to say that they are crystal clear in the obligations for nursing, it would be an understatement. In fact, the article I mentioned early on that I saw today spoke very clearly that DEI continues to be an underpinning of nursing and cannot be ignored and simply tossed away, and will continue to be valued. And many other professional associations have followed suit in that. Social work and NASW are another that they have said social workers are not neutral. They have long fought for and advocated for the rights of marginalized and minoritized and vulnerable communities, and will continue to do so. I recognize on this slide, well, I could be here for an hour, and this is a presentation of itself. Those that were at CMSA recently, I presented on anti-oppressive practice, and I believe that you can listen to that session via the Education Resource Library for those that are interested, because it's an hour. But let me say this, psychological safety is paramount, and for Exit 2, we do have an obligation to make sure that anyone that works with us feels safe, seen, heard, valued, that they're comfortable in the space, that we can take care of them, that they feel that we're hearing them, and that these tenets of anti-oppressive practice, which is a theoretical perspective that started in social work, but has the umbrella of these 5 tenets, is adhered to, that we're attentive to cultural humility, that we're aware of biases. I'm one of those folks, I get it. There is unconscious bias, but bias is bias and it's there, and we need to name it and address it so it doesn't impede patient care or workforce safety. But I'll save that tangent for another time. We need to make sure that in the context of racial equity, we're being attentive. I know microaggressions and microinsults is a topic that this chapter has had presentations on multiple times. From an anti-racist perspective, we have to make sure that social justice and advocacy is being adhered to, and that trauma-informed practices and shared decision-making are employed, and not just words that are part of a mission statement for an organization, but everyone knows how to operationalize them. Okay, got through that one in a minute. We've got to make sure that we are advocating at every level. At the macro level, at the highest levels of legislation and for reimbursement and funding, within our organizations, our communities, from a workforce perspective at the meso level, and of course, making sure that our patients feel safe, seen, heard, and valued. And finally, our last step. See how quickly we got to that? Modeling and mentor. I ask everybody to stop and think, how do you model and mentor ethical equity advocacy for any patient population you work with, right? Spanning peds to older adults. How do you set that tone for the workforce and model it with every step you take and every word that comes out of your mouth? Those that know me know I'm pretty consistent in my approach, and I have been for the 40, goodness, 3 years I've been in this industry. That's scary. I started when I was 2. Before we were calling things social determinants, and before we were calling things health equity, and there was such tension about use of words. We were employing and using shared decision making and partnering with our families and our patients and our care teams, and making sure that they were informed and using teach back and methods to hopefully guarantee a level of health literacy and understanding, and that we were in a place where we were respectful of who the person was and the messaging and treatment plan that worked for them, not where what the well-intended practitioner wanted them to be. And that we made sure there was staff that looked like the patients, that at times we could look like the patients, so that they reflected and felt that sense of psychological safety. And that when we say we're allies, we really say and mean it, and we continue to advocate with every fiber of our being in that space. In the end, we got to get rid of this, folks. We must extinguish medical gaslighting. That is one sound way that we can achieve patient-driven, patient-inclusive care, quality-driven care. And we all have a space and a say in how we deal with that every day. I know I've ran long. I can't thank you enough for hanging in there. Lots of resources. I know these slides will be shared with you. Lots of references, I promised. They're all active links. Finally, at the last slide for questions, as there may be. I know in the interest of time, please, if we don't have the time to answer questions, and I'm going to defer to June and Maureen for that, I'm happy to respond to your emails. You can always reach out to me for further clarification or dialogue. And with that, June, there you go. I did my part in an hour.
You did. Thank you so much, Ellen. That was an amazing lecture, so informative, and I know that it will lead to an improvement in care. Thank you so much. So I'm seeing in the chat, there's a lot of thank yous. And so, okay, so there may not be any questions that I see because you covered everything. You
I
have
tried.
room for questions because you answered us all. See, I get great presentations. Thank you. So that's what.
But I will say this, Jen, I think sometimes my experience has been with these topics that sometimes I hear from people after, right? Because it's
Right.
hard. And thank you for the folks. My friend is dearly missed. And it's just a year since it all went down. And I still can't believe it, and still have some of her ashes that her partner gave me to put in water, because she loved water. So we have to get her in every bit of water everywhere. But
Yeah, I'm sorry too for that
you,
loss.
you know, we're real people, right? Real people have experiences. We were real people before we became the practitioners. And I think while we have professional boundaries and want to be effective with our families, we have to be sensitive to the issues that impact them most. And this is a biggie. And while I'm grateful for the opportunity to talk about it, I'm especially grateful to talk about it for peds, which we often ignore. And I was just talking with someone about pediatric mental health and my next book, and I was saying, hey, yeah, there's a whole. I'm making sure every chapter has stuff on peds and youth,
Oh,
so you won't
wonderful.
feel right because we have to make sure that we hit this if we're going to take care of whole person care and the whole lifespan and every dimension of it. So I
Yeah,
will be available and happy to email to anyone that might have further questions.
yeah. And just to jump into to tell you, like Ellen's on LinkedIn for those of you on there all the time, and she's always sharing articles. I mean, she's an education in a post. You are. That's what I always say.
Thanks,
Thank you
Jen.
so much.
Oh,
And
thank you.
everybody stuck around. So, I mean, that's a compliment to you
Thank you.
too. All
Thank
right.
you all.
Thank you, dear. So, I mean, just to give people last minute directions, to let you know that when you leave, what we recommend is that you go through either the red end button or the leave button. Because if you do that, then you're going to go right to the eval and you can complete it. But if you don't leave through one of these modes, or if you just don't have time. Maureen's excellent. She'll send it to you with at least within 24 hours, and you can fill that out and you'll get the CEUs. Any issue, just call the office, CMSNE, and Maureen's highly accountable and will help you out. The other thing is, of course, if you want social work CEUs, there's when you finish the eval, there's going to be your 10 questions that you need to answer to get those. Let's see what else. So I don't, da, 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 da. And I think that's it. So we can't thank you enough, Ellen.
My pleasure.
It
And
was delightful.
I'm just remembering for folks who might be CMSA members, as part of your member benefit, you have access to journals, right? There's CMSA Today, which is the association's it's so much more than a trade journal, but that's the term coming to my head. And then there's the evidence-based journal, which is the professional case management journal. I wrote a big article on this topic for the Heartbeat of Case Management column a few months ago. So those who are members, you go to your CMSA login site, go to the cmsa.org, log in, get to the member site, scroll down, it says journals, hit PCM Journal, boom, and you'll have free access to all the wonderful research in that journal. And because it's an evidence-based and scholarly journal, you need separate access than CMSA Today, which you can just go into. But you can certainly access the article in PCMJ on Professional Case Management Journal. If you are not a member and you work for a hospital or healthcare system, a lot of academic and institutional libraries have access to the Professional Case Management Journal, so they might be able to access the article for you here. And I think I included it in the reference list. I'm not sure if it was published yet when I had done the latest update, but you can always access it or email me and I'll let you know where to get it.
Wonderful reference. That helps everybody. All righty, dear. It's been a pleasure and a great education.